He has numerous publications and research on various topics, including clinical electrophysiology, stroke, and critical care neurology. His areas of interest include movement disorders and Parkinson's disease, cognition and data sciences, and today's topic is what's new in movement disorders.
Uh, Good morning, and everyone. It's nice to be back here. So I'll be talking about what's new in movement disorders. So first, dealing with what's new. It may be there may be new things in terms of diagnosis of diseases, because some of these diseases, as we've seen, even cognitive disorders are so difficult to diagnose, and whether there's a new change in management or new drugs, new treatment available. The other thing is also important, if just because it's new doesn't it doesn't really matter if the treatment or the diagnostic test is not available in our country or our patients per se. So just a brief overview, we have movement disorders usually imply basal ganglia pathology or cerebella or the circuits involving these places. So these movement disorders occur despite normal cognition, no deficits in power, sensation, or cognitive impairment. So largely we have two groups, the hypokinetic or disorders of reduced movement, and this is the largest group of movement disorders in which the most important, the diabetes of movement disorders is the idiopathic Parkinson's disease. And there are the disorders of increased movements. Those are hyperkinetic disorders. We have tremor, dystonia, chorea, macros, and many others. Uh, Maximum research in the last few years has been on Parkinson's disease because the incidence and prevalence both have been increasing quite significantly. And in India, we see a lot of PD being very young onset. So it's basically a neurodegenerative disorder secondary to synuclein aggregation, neural degeneration, and we all know the typical manifestations. So this is all the presentation will be in this pattern only. So what's new when it comes to diagnostic facilities in Parkinson's disease? So one extremely exciting development is availability of alpha-synuclein RT-QuACE assay. So far we didn't have a means of diagnosis, or all the diagnosis was clinical or some associated clinical tests, investigations. We all know that MRIs are usually normal. And when we were doing synuclein assays per se, they were not really helpful. So what is now known that synuclein misfolding is a pathology, and if there's a way to detect alpha-synuclein misfolding, then we'll be able to diagnose Parkinson's more specifically and much more sensitively. How it is done, I'll come to it in a bit. So basically, this assay detects misfolded alpha-synuclein, which is the pathology of Parkinson's disease. It is available for clinical use, and it is available as research in our center. I don't think anywhere else in India it's available yet, and it's fairly cheap. It's just costs around 5 to 10,000 as so far. Yeah. And we'll soon make it a clinical test also available. We've been doing it for almost 6 months now. The other diagnostic advance is genetic studies. So genetic studies have been available for long times, but now with improvement in data science and much more coverage, much more populations being studied, there are basically two types of genetics in PD. So we have the genetic mutations, novel mutations, single monogenic disorders that can cause Parkinson's disease, and we also have genetic risk factors. So both are being covered more and more. Much advanced genetic studies are available now, including long read sequences, and they are available for clinical use. And we are doing it in our patients as well. We are doing it in our department also now. Something which will sound strange to you is sebum analysis, and basically it looks at unique lipid signatures, and I'll come to it soon. It is right now not available, but yes, we can do it in our center as well. We all know that sleep studies, Parkinson's disease has REM sleep disorders. So sleep studies are definitely available, but we have to nowadays much more simpler methods, and home-based sleep studies are available just for the diagnosis of REM sleep disorders, and that make it very easy and availability, and it's definitely a significant advantage. Wearable monitoring devices. So with better and better data analysis, we are able to now, just put a monitor or multiple monitors on patients and see the different movements. And I'll come to that also in a bit. 7 Tesla MRI is a very exciting technology, which, of course, not just in PD, but multiple other disorders. It's still not available for clinical use anywhere, however, and definitely not available in our country. So this is the one of the important diagnostic tests, that's alpha-synuclein. We either take a skin sample, CSF sample. These two are definitely diagnostic, and we have very good results with these two. With blood also it can be done, but the technique is a little difficult, and we're just improvising that. So basically what happens is misfolded synuclein acts like a prion. So if you add normal synuclein to misfolded synuclein, it misfolds the other ones also, and that causes an aggregation. So you take the sample from the patient if it is abnormal, and when you add normal alpha-synuclein, it will keep on aggregating till you get a large fibril, and that can be detected as uh, 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 via fluorescence. So in patients with PD, suddenly aggregation will give a nice rise in fluorescence, which we can use it for diagnosis. We've done it on some 21 patients so far, and for CSF and skin, it has shown very good results. So I was talking about sebum analysis. The origin is from this lady. She's a nurse. Joy Milne is a nurse. Uh, she had this uncanny thing that she could smell patients with PD. So in the ward, she could go and find out which patients have PD. So uh, initially, people thought it's just a quirk or something, but this other lady thought to look into it. And she realized that it's not just people. Even when they close, when they take out, she can still smell those. So she realized that it must be the sweat or sebum, which is giving to a unique olfactory signature. And it's a very simple test which they did afterwards. It's just they did measure all the volatile compounds present in sebum, and they have found some signature of this that can lead to a diagnosis. It's still under study, but it's already showing good results. If it's so, we can, it uses GCMS, which is there in our department also, and can be used very easily. This slide shows various wearable monitors. These are the same monitors which are there in our phone or smartwatches. So inertial monitoring units, measurements units. So basically these track movements in 9 axis, and they can be used to define well-defined tremor or dyskinesia or gait or freezing of gait. Now, they can be used for diagnosis as well as management. So what the next step in Parkinson's disease is, so normally what we have is, we ask the patient how much is the tremor or dyskinesia, is it adequately treated or not. Now that can be done automatically if we have, for example, a deep brain stimulation or a infusion pump. So that's going to be the next step. When it comes to therapeutic, DBS is already an established mode of treatment. What is advanced is something called directional leads, and I'll come to that. Basically, there are more contact points, and they give lesser side effects. It is available for clinical use. It is available in India. We have done one patient with DBS with directional leads. Only problem is it's expensive. It comes to around 12 to 15 lakh Indian rupees. But it gives a really good response. The other one is adaptive deep brain stimulation. So right now what we have is you install a deep brain stimulation, you monitor patient clinically, and you adjust the current. However, the current will be static throughout the day till you see the patient next time and ask whether the patient is doing well or bad. Uh, Adaptive deep brain stimulation senses the the recordings at the site where it is the contacts are placed, and it can automatically change the current based on some parameters. It is available for clinical use in limited settings. I think in Japan it's already started. I'm not very sure, but if it's still in research mode or as clinical use. It's not yet available in India, but the devices are available. It's only the software which is not available now. In fact, one of the patients who we did DBS, we can upgrade it to an adaptive deep brain stimulation. Focus ultrasound is a new technique. Uh, Basically, it uses 1024 ultrasound lights which focus at one single point and create a lesion. So earlier we were doing lesion surgeries. Now we can just do it using ultrasound. So it's a non-invasive invasive technique. And basically you ablate targeted brain lesions. It is available for clinical use. It is available in India at one center in Coimbatore. The only problem is that for PD, it's very expensive. It's even more expensive than deep brain stimulation, costs around 20 lakhs as of now. And the long-term response in Parkinson's disease is not known. In essential tremor, it's fantastic. There are two drugs. Both are actually advanced versions of known drugs only. Opicapone is a COMT inhibitor. We are already using entacapone. Basically, it acts as a reduces degradation of levodopa and thus prolongs the action of levodopa. However, it's shown really good response as compared to entacapone, and other advantage, it's a 1 day dose only. It is available for clinical use in US and Europe in countries, not yet in India. And the only problem that we expect is the price. It may be a little too high for our patients. Istradefilin is basically just like caffeine. It's adenosine A2A receptor antagonist. It's a little bit more potent. So what it helps in PD per se is it reduces the off episode. So when patients go off, this basically increase. Like we all have caffeine, and our movements become much more stronger and faster and much more accurate. So it's expected to be having a similar effect. But more importantly, the people who use it, they say that it improves mood and apathy significantly. Again, effect is similar to caffeine, just that it's much more potent. It is available for clinical use, not in India yet. And hopefully when it comes, uh, it may be applicable to our patients as well. Other two drugs, they're not new drugs. They're just, it's the same old, since 1960s, we are using levodopa, but a new means of administration, and that is inhaled levodopa and subcutaneous levodopa. Inhaled is usually used for as a PRN drug when the patient cannot take medicine or it's not have or is not having good response. Uh, However, subcutaneous continuous infusion has been shown to have a very good improvement. It basically bypasses all the GI absorption, and people who have used it have are really praising it. It is available for clinical use as well in Canada and some European countries, not in India yet. It should be a very good means of treatment. The only probable concern will be cost. Another exciting drug, a trial of which came was a GLP-1 agonist, supposedly neuroprotective, that's lixisenide. And then we have the stem cell transplants and gene therapies, which are all under trial. So this is what I was trying to say. So current leads are like this. So we have 4 leads, and when you switch on a lead, it just you have the current field which is just around the lead, that particular lead. However, if you have a directional lead, you can put it in one direction. So if you have a lot of internal capsule side effects, then you can just turn towards one side and you can reduce those side effects. You can also stimulate at 2 different points as well. What we have used is this one, which has 2 ring leads and 6 middle directional leads. This is the mechanism of COMT inhibitors. Is basically reduces levodopa degradation. And this is the trial of lixisenide, which was there in PD. It showed some difference, improvement rather in UPDRS at the end of trial. However, it was 1 year trial. Longer trials are still underway. And if it comes positive, we can use maybe not lixisenate, but other GLP-1 agonist as well. Coming to hyperkinetic movement disorders, there are not many advances, and most of them are derived from PD itself. So we have genetic studies, long read sequences, better databases, and all these are available in our department, in our hospital and our department as well. The wearable monitoring devices can be used for diagnosis as well as for sometimes for therapy. And these are also used available in India, and we are using them as well. Again, deep brain stimulation with directional leads is again helpful for some of the hyperkinetic disorders as well. This is not been studied in hyperkinetic movement dystonias, for example. Focus ultrasound for tremor, it is an FDA approved treatment and it's fantastic. The only problem is cost. VMAT2 inhibitors, we currently use tetrabenazine, and we have two newer drugs for that, which are slightly better, but of course they are expensive. They are not freely available in India, but you can import them. Now, the other thing is resurgence in traditional surgery. So with now that we know focus ultrasound helps in some of these patients, so the traditional surgeries is just an additional hole in the cranium. A lot of centers have started doing old surgeries, lesionectomies, and we have also done for one patient for dystonia. And it's really helpful. It's much cheaper, and it's definitely available in India as well. Thank you so much.
Thank you so much, Atif. So what we'll do next is the critical